Well, hello, can you hear me? Hi, yay. My name is Edith Parker, and I'm Dean of the College of Public Health, and I want to welcome everyone here today, including those of you who are online. I do want to apologize to those of you online. We're having a technical problem, so you will not be able to see the speaker's slides, so I do apologize for that in advance. So we have organized this panel today for a few reasons. One is, of course, to give an update on coronavirus. Second is really to give a place for our students, faculty, and staff to really think about, reflect upon public health practice in real life, because this is public health in real life. And this really live example that I should say is a very fluid situation, both nationally and internationally, with the spread of the virus, as well as here at our institution. As many of you may have, you've looked at your email in the last 5 or so minutes, know that it has just been announced that the U of I is suspending face-to-face instruction for the 2 weeks following spring break. The university will move to virtual instruction beginning March 23rd and continue online classes through at least April 3rd. So I'm sure many of you are thinking, well, what does that mean for me? And there will be further communication from the college coming out, we hope, this afternoon. I should say that our staff and faculty have been great, and the leaders in the college, of starting to plan for this potential outcome. And so we feel like we have plans, and those will be communicated to students, as well as some of the other aspects of what is contained in the email. So some of this is with the fluidity is going to be coming in the next few days. And the situation may change. You know that we are under a ban for international travel. There is some discussion, as other institutions have done, should we look at domestic travel? Decisions have not been made on that, but certainly I think the leadership of the university, as well as the regents, are doing exactly what they should do, along with our Iowa Department of Public Health and our governor's office, which is to think first and foremost about the safety of our faculty, staff, and students. And that should be our top priority. I think I should also say that our second priority is certainly for those that are facing graduation, to make sure that whatever we decide eases that and makes that possibility. So that will be another priority of the institution. I would say to the students, particularly, and faculty and staff also, that please, as you leave, if you do leave for break, and during your break, do remember to check your University of Iowa email early and often. That will be our way of communicating with you, as well as the coronavirus website that has a lot of information for the university, and also Iowa Now. And I also want to remind you to wash your hands early, often. Okay, so today I want to introduce our panel first, and I should say this is also, I think, a great opportunity to us to highlight our excellent faculty, staff, and students in public health. Oftentimes people don't know what public health is. This is a great opportunity for us to really demonstrate what it is and its importance. So I want to start with Dr. Michael Pintella, who is the director of the State Hygienic Lab and a clinical professor in our Department of Epidemiology. Robert Nisgoda, who is a PhD student in infectious disease epidemiology, and also is the former Taney County in the Branson, Missouri area health department director, so has some practice experience with this topic. And finally, Laurie Wagner, who is our interim director of our Institute for Public Health Practice and the coordinator of the Midwestern Public Health Training Center, and has a lot of expertise in disaster preparedness. So I'm going to turn it over to Mike. I think I do have some slides I did want to share. One was just the announcement that went out, so that will, you'll see that in your email boxes if you haven't yet. The other is to remind you of this great resource of the coronavirus website that the university has put out that has frequently asked questions, and I think it's a very fluid document. It is updated not only daily, I think throughout the day, so please pay attention to that with some of your questions. And then I'm going to turn this over to Mike, I think.
Okay, thank you, Dean Parker. I'm going to take the mic with
Okay.
me because I won't be able to hear. Thank you. Good afternoon, everyone. Pleased that so many of you are interested in this topic because it's been filling all of my time up for the last several weeks. And I thought we'd start by just talking about putting this in perspective, that we face emerging infectious diseases all the time. And if you look back to 1970s through 2010, in the 2010s, we saw the case of Ebola in the United States. That created a lot of concern that we would see further cases. Fortunately, only 2 people acquired that infection. Uh, and we've seen measles outbreaks that have been devastating in certain parts of the country. And Zika virus around 2016, I believe, if I recall correctly now. And then we have emerging pathogens that you probably haven't heard much about, like Candida auris. So having an emerging pathogen like COVID-19 is not a new thing for us in the laboratory or us in epidemiology. We're always facing this challenge. And we always like to say the next emerging threat is only a plane ride away. And this really proves it to us too, or a cruise ship right away, I guess we could say. But just to start a little bit about coronavirus, these are enveloped RNA viruses. They rapidly mutate, so they're changing all the time. And we have various forms of the virus. And this particular strain is of a specific lineage B. And it is related to the SARS that is not SARS-CoV-2, which I'm becoming more familiar with that name now, but it's very much different, and we don't know everything about this virus, and there's sequencing information, and it's going to be studied for a long time until we actually understand it well. So some background about coronaviruses. There's a very large family of viruses. Animals get infected as well as people, and we know of 4 common ones are listed there, the 229E, et cetera. And usually we get these and they're self-limiting. Now that we have these multiplex PCR assays, people will get identified as having a coronavirus. It usually doesn't tell you which one of the 4, but most people will get infected at some time in their lifetime, and we detect them all the time. There are 3 rare ones, this new COVID-19 being one of the rare ones, but another one that Mediterranean, or Middle Eastern rather, respiratory syndrome virus is a coronavirus that's thought to be the source from camels. We have seen a case in the United States from someone who traveled to the Middle East and then traveled through Chicago into Indiana. And then, of course, SARS-CoV, which was around 2003. So we've first identified this COVID-19 in China, and there were many initial patients in the outbreak, and you've seen the numbers. But now in China and elsewhere in the world, like Italy, Iran, Japan, and South Korea, there's, in some parts of the US now, there is human-to-human transmission in the community. All the ones we've seen in Iowa so far, and I'll show you the numbers in a minute, but that's only been travel associated. We don't know of community acquired yet in Iowa, but we assume that that will happen very soon because it usually the travelers then infect people in the community. So anyone in close contact with someone who's been diagnosed with the disease is at risk. So close contact is defined by 6 feet because of droplet transmission. Droplet transmission is the primary route of transmission. So when we speak, sing, cough, etc., we're producing droplets that are expelled through our mouth and nose, and those are what's infectious to other individuals. The virus can also land on surfaces, and then we touch that contaminated surface and touch our eyes, our nose, our mouth, and we can contaminate ourselves with that virus. So that's the 2 routes of transmission, but mostly it's the droplets that we're most concerned about, because once it lands on the surface, it will die. It all depends on the conditions in the environment, how long that will take. So people are most likely contagious when they are most symptomatic. And most people will get a mild disease. This gives you a timeline of the number of confirmed cases and the number of deaths that have been reported during the January time period, and shows how rapidly this virus has spread throughout the world. And it continues to spread. So this is a good WHO map that is dated March the 8th when I put this on there, that has the latest. But of course, those numbers have changed dramatically. Cases in China are declining, but elsewhere in the world increasing. And it's gotten a lot of attention in the news. And I'm sure that you have all been inundated of all things that you can be reading about this that is happening everywhere in the world. And this is data from the US at a glance, and this was from yesterday: 164 cases, 11 deaths, and 19 states reporting cases. Uh, and the problem is, I read this morning that it was up to 34 states reporting. So additional states are added constantly. So it's very widespread. 36 travel related and 18 person to person. So we're getting community transmission in the US. And here's a map of the US. Of particular concern is the West Coast, with Washington, Oregon, and California, and then New York City. I think they had 12 cases yesterday detected there. Massachusetts is heavy, and Florida has been identified as heavy number of cases. I haven't seen where in the state, but the first cases occurred in Hillsborough County in the Tampa Bay region. So March 6th, we were at 11 asymptomatic individuals are being monitored, and we had 0 positives. But then this weekend, we were, as of March 9th, we were up to 8. We detected the first 3 positives on Sunday. The lab worked the weekend on Saturday and Sunday. Sunday, we had 3 positives from the same county, and that was Johnson County. Now we're up to 13 positives as of today. So it's multiplying, but again, all travel associated so far. And I want to point out to you how an infected patient is really surrounded then by a public health system. And you have to look at it as a systematic approach, because that infected patient has that risk of passing that infection to others in the community. But through the efforts of the epidemiologists at the Iowa Department of Public Health and those at CDC and the lab testing at a state hygienic laboratory, we can surround those patients who get infected so that people in the community are protected. So it's a system that's slowing the transmission. And by slowing the transmission, we hope to lessen the impact from the viral infections. So this is a typical pandemic curve, that with or without interventions, but you see a logarithmic rise and acceleration of the number of cases, and then go through the peak numbers and a deceleration later on. So if you look at prevention efforts, should reduce that and slow the number of detected cases. So that's what we're after with this. WHO recommends intervention that tests to identify the cases, isolate infected patients, trace the contacts that are people at risk, then will go into quarantine. And then when you detect clusters emerging in communities, then cutting back mass gatherings, prohibiting mass gatherings. So that's what they are doing in other parts of the world. And when you think of when to do this is really important. So the regent's message to us about not, after spring break, not meeting in person, is an effort to prohibit that mass gathering to stop that transmission. Since it's a 14-day incubation period, that makes sense to not hold classes for 2 weeks. So this is the test kit that we're using. We went live February 27th, and the CDC recommends, as Dr. Parker showed, wash hands often, avoid close contact. That's that 6 feet barrier that you should use. Stay home if you're sick. Even if you're thinking, oh, I may be coming down with something, now's the time to protect others and stay home and be sure that you're not transmitting it. Uh, Cover your coughs and sneezes, clean and disinfect with good products. If you are sick, wear a face mask when you're around others or when you enter a physician's office or clinic or emergency room. If you're not ill, do not wear a face mask. Uh, and here's some reliable websites that I find very helpful. So I thought I'd share them with you. And that's all the information I have, Robert.
Thank you. All right. So Dean Parker had reached out to Johnson County, and they're kind of busy right now. So that's why I'm here to give you my perspective, a general perspective about the local public health response and general public health response to pandemic. A little bit of background about me. I started in Taney County and emerged as a epidemiology specialist, the emergency response planner. So in 2006, under a federal contract, I was actually developing pandemic plans in response to H5N1. And then in 2009, 2010, I had never thought my wildest imagination that I'd ever implement a pandemic plan. And then H1N1 developed, and I led that response in Missouri. But that is just to let you know that there is plans in place, local, state, and federal. They're all working together based on CDC guidelines and frameworks that have been developed for many years. These have been developed, they've been exercised. There's been a lot of coordination between public health, emergency response, healthcare systems, healthcare coalitions, and that sort of thing. So after so many years, there should be an integrated response that is working on all these domains. The pandemic levels that were developed several years ago have 6 stages. We're basically in interval number 4 if you follow these guidelines that were developed for influenza. The World Health Organization is not declaring it a pandemic just yet. Oh, they did. Okay. Last hour. Okay. So yeah, things are moving really quick, and that's something that we identified in 2009, 2010 is things constantly and rapidly change. Uh, so in terms of the response domains here, for each of these intervals, there's actually a huge number of roles and responsibilities that not only involve public health, but also involve emergency management, healthcare, schools, business leaders, and those types of things. So really what we're seeing now is depending on which community you're in, because again, this is very fluid, very flexible situation and flexible plans. But within these domains, a community that is experiencing these early incidents of early transmission, you're going to have incident management systems being activated. You're going to have potentially the county emergency operations center being activated. You're going to have those community partners, the response partners coming together and starting to put things in motion. Depending on how everything develops, you're going to have community mitigation plans being discussed, things about like event cancellations, school cancellations, university changes, things like that. So there's a lot of non-pharmaceutical interventions that can actually be implemented in these early stages that'll help flatten that EPI curve, which is extremely important because you don't want to have a massive amount of cases all at once, right? Because it's going to overwhelm the healthcare system and everything else. You want to flatten out that EPI curve so that the number of cases will be stretched out over time, which means the healthcare systems can handle it. Communication with the medical care and different countermeasures, the healthcare system especially, understanding how they're going to respond to the surge that's going to most likely be happening here for 2 reasons. One, you're going to have actual cases, but then you're also going to have worried well. Okay, these are people that think they have, because it's on the news, they get concerned. All of a sudden, that shortness of breath that might be due to anxiety is now, oh my God, I have coronavirus. So you're going to have all these people that are going to surge into the healthcare system. You have a risk communication plan to make everybody realize, take a deep breath. If you don't have this symptom and this symptom and this symptom, you don't need to go to the doctor. If you do have these symptoms, then you report here. So there's different things that in each one of these domains that will help manage the community's response, as well as manage how the different entities in the community are going to be able to come together to address some of these things. There's going to be a lot of state and local coordination, as well as coordination between laboratories and healthcare systems regarding testing and that sort of thing. But also in terms of surveillance and epidemiology. Right now, this is where a lot of the work is going to be focused on identifying those early cases, identifying contacts, and making sure that there's some sort of isolation and quarantine that's happening so that you can stop that initial spread. Um, at this point, don't know if they're going to be able to contain it or not, but that's always that possibility they're going to be able to identify those early cases, get the contacts identified, and stop that transmission, or in the very least, lower the number of people that are getting exposed, and therefore reduce the case count over time. So what could happen during a severe pandemic? When I was doing my planning, I looked at the worst case scenario, so it gets pretty dark, all right? So this is, so just thinking about potentially what could happen. In a lot of the training that we went to, they said potentially you could have 40% absenteeism in every industry, okay? Trucking, IT, law enforcement, fire, EMS, healthcare, public works. So once you start thinking about those vital systems that keep our society afloat, things start to fall apart pretty quick, right? If you don't have trucks coming in, you don't have goods and services, okay? We live in a just-in-time supply delivery system world, okay? There's not big warehouses behind Walmart. They get trucks in constantly because when you buy something off the shelf, it goes into the inventory system. They say, hey, we need another can of beans. So they order a case and it arrives the next day, right? So what happens if 40% of the trucks don't show up? What happens if 40% of the trucks delivering gas don't show up, okay? Think about things like healthcare supplies. You have masks and gloves and all that stuff, PPE that you generally need. If those supply systems break down all the way back to manufacturing in China, which is where we get a lot of the stuff, they're not manufacturing anything right now. What happens then downstream here, okay? So these are the things you think about in terms of what could possibly happen. Now, there's been some concern about some pharmaceuticals being not being able to manufacture, but it's not to the point where the world's ending. So this is worst case scenario type things here, right? So what we have to look at is the characteristics of the virus will cause a certain number of illnesses in healthcare and hospitalizations and that sort of thing. But a lot of the concern we have is how people react to it, that social and economic disruption that's going to affect the communities. So with the public health planning, we work with those business leaders, we work with those partners to say, hey, how can you get your employees to work from home? Because if people aren't working, they don't get paychecks, and most people are living paycheck to paycheck, right? If you have schools closing down, what are you gonna do about childcare? If you need healthcare workers and EMS workers to show up, their schools are out, so what do they do with their kids? How do you get your employees to take some steps for family preparedness so they actually are able to leave home because their family's taken care of and show up for work, right? If you have disruptions in the healthcare or the delivery systems, how do we get those needed supplies in the cities to make that happen? So all that planning and discussions have been going on for a long time. So we'll see what happens here in the next few days as these things start developing. And also have to think about vulnerable populations. There's a lot of people in our communities that have underlying conditions that are going to impact how they handle this disease. Whether it's diabetes or heart disease, cancer, whatever, those are going to be the people that are high risk for those hospitalizations, hospitalization, ICU, and mortality.
So just to take one step back and put this into perspective, public health has been involved in this, as Mike said, for years and years and years ago. We actually got a grant in 2000. We applied for a grant with CDC. And so it was before 9/11 and got organized. And actually we had a meeting on 9/11 in Atlanta. So that was our first real run with preparedness to figure out how do we get home since everything is shut down. And a lot of things go through your mind like, gee, wish we would have been prepared for this. But we did get home, and it really brought about the notion of we need to have plans in place. We need to have a well-trained workforce. And now public health is really in the limelight. People understand that public health plays a very major role in emergency preparedness. And so back in 2011, this is the second edition, the National Preparedness Goal, sorry about that, was released, which said a secure and resilient nation with the capabilities required across the whole community to prevent, protect against, mitigate, respond to, and recover from the threats and hazards that pose the greatest risk. And everyone knows that there's not one entity that can take care of that, but we have to come together, as Robert said, together and be able to respond, to plan, prepare, respond, mitigate, and recover together. And so out of that preparedness goal came some capabilities for public health. And so there are 15 different capabilities that public health is required to be able to carry out. And one of those is community preparedness. And within community preparedness, you can see there's several things that have to be carried out, like the health risk assessment, knowing the legalities, the roles and responsibilities, the incident command system, which is off on the right here. I think, Robert, you were talking about that too. We have to have some way to have some coordinated efforts across agencies. We have to be able to say the same message, be carrying the same message, knowing that we're getting accurate and credible information, because the general public depends upon that. And if we want them to react and to take action, they're going to have to get that current information from people that are reliable and not mixed messages. And so quickly, protecting the communities, the key role then goes back to community preparedness. It's everybody's task to be able to prepare and to take care of themselves, or take care of others. So public health in this role has to determine the health risks, develop and align plans, as Robert said. I remember I was at one meeting with Johnson County Public Health a long time ago, and they said, well, the plans for such and such reflect that we do X, Y, and Z. And they said, we don't have that capability. So when you come to an incident, you don't want to find out that you're supposed to carry out certain roles and responsibilities, but really don't have the capacity to do that. So that's why advanced planning, building these partnerships and relationships within communities is so critical to planning and response. And then engaging the entire community, because everybody can do something. It's not like you can't prepare yourself. You can to some extent. And then making sure that there's inclusion, that you include the whole community. And CDC has a great infographics within the community, bringing in the laboratories, the schools, community members, health departments, of course, healthcare professionals, the health system, businesses, and even wider, the schools, K through 12, they have a lot of guidance out. IDPH, I don't know if any of you have been on their webinars recently, but they've been having webinars on how to prepare for schools, for work, first responders. And again, think of those first responders, because they're out there in front every day dealing with this. So what can you do yourselves? Again, I think we've heard this time and time again. Follow precautions, get plenty of rest. Again, if we go online, you can, or we are going online, you can be in your pajamas and save an extra 20 minutes of dressing and commuting. Eat nutritious foods, take a break from the media, get away, because it's everywhere. And just getting away for a few minutes, going out for a walk, and supporting each other. Be a lifeline for each other. Build resilience within your community, whatever your community is, and then stay informed. Situational awareness is knowing what's occurring around you and then using that information to protect yourself. That's it.
Thank you again to our panel. I think we're going to open it up now for questions. So if folks can raise your hand, and we'll have some mics, I think, in the up. Got one right away.
Hi, thank you very much for this wonderful and experienced set of voices. It's really a wonderful panel. I wonder, Mike, if to the extent you're able to share with us, if you could comment about the availability of testing and the sort of the volume of testing that the lab is experiencing, and the kinds of activities that you're seeing on on the ground there at the lab.
It's at that early phase for Iowa, so we had I don't know, remember the exact numbers, but yesterday we had 41 tests. Today we only have 33. I would have thought it gone up. So that's a good sign. But right now, Iowa Department of Public Health is the gatekeeper. In order to get a test, you need to have someone who has the signs and symptoms, has the illness, seriously ill, really, and or has been exposed to someone who has been diagnosed as the case. And for those, we are doing the testing. That's probably going to change because the message from Washington, D.C. is that anyone who wants a test can get a test. That will get to the worried well that Robert mentioned. So that's going to be a big problem. On the flip side of that, we have commercial reference laboratories like Quest. Let's see, Mayo hasn't started. LabCorp is testing, and I think ERUP will be up soon. And so we have those 4 major reference laboratories are in the process or have brought on testing. Quest is only testing in 2 locations right now, one in California and one in Virginia. But they're supposed to be expanding that to other sites. And once they get that expanded, it will probably be able to test several thousand each day because they have a lot of resources. But we don't know when that will be available. And I don't know what LabCorp's availability is. I do know that other hospitals, larger hospitals in particular, could bring on a test, and some manufacturers are developing the test for the instruments that hospitals already have. So that will alleviate it. But that's probably weeks away, maybe longer.
Comment today. When the dust all settles, assuming we come out of this all okay, what are some ways and what are some metrics that we can look at to make sure that things were done right? Maybe holding the systems, but also our leaders and elected officials accountable for the system that we had in place and how to make it better in the future.
All right. Okay. That's a really good question. I think if you look at a lot of the non-pharmaceutical interventions, there hasn't been that much research to say, yeah, this works and this doesn't. So in a lot of that, what you asked about, we're going to have to start at probably ground zero. It's been quite a while since we had a massive pandemic. If you look at 1918, the Spanish flu, what we've seen recently with H1N1, even before then, you're talking, the 70s and then even to the 50s for, larger pandemics. So opens up a lot of opportunities for research. So if you need a thesis or dissertation topic. But the idea, I think, is there's going to be a lot of politics involved. There's going to be a lot of looking at the data from a lot of different perspectives. And I think the important thing is to try to figure out a way to find out, what was effective, what wasn't, without getting into the politics or finger pointing or things like that. That's extremely important because, we don't need that. We need to learn from this and make things better. And
I think one thing that is in play after any incident is they do hot washes and write after action reports to find out where those gaps could have been within a particular agency, and then step back and look at a systems approach to that. So those are, and I can't tell you exactly what the metrics are, but setting up systems, how quickly did we respond? There are metrics out there that CDC developed a long time ago. How quickly can you stand up your EOC and things like that. So that's a part of the big emergency operations center, which the university has.
I think the primary metrics I'm going to probably use, just from my perspective, for an after action for the laboratory is how many days did the response last? And were we able to keep up with the demand for testing during those days? What was our backlog, if there is any, of tests that did not get accomplished? And how long did that last? So those will be what I look at, plus the number of man hours that were devoted to it, the amount of effort that had to be invested into the response. So those will be my metrics, because a response like this is expensive. You didn't ask that, but I'll add it. It's an expensive thing to respond to this.
I think back to the slides that both Mike and Robert showed, I think and there was a New York Times article you might have seen about that, sort of trying to flatten the EPI curve and not overwhelming the health system. So I think that certainly is a pretty large metric that we would want to look at in terms of evaluating how successful our preparation has been. Still needing to be confirmed by the CDC, and if that's going to continue into the future?
Yes, right now, anything we report out as positive is called a presumptive positive because it's pending confirmation. It typically lasts for at least 5 tests, and sometimes they go longer. And they have not indicated to us that there's a change, but I have a phone call this afternoon. They may indicate it then.
I just had a question about, a lot has been stated about like international travel, obviously, but what are your guys' recommendations as far as domestic travel within the US?
Okay. Well, I could say I canceled my trip to Florida, but that was not because of transmission in Florida. I think that my recommendation would be to look where you're going and make the determination based on where you're going and the cases that are occurring. But I don't think there's any reason to cancel U.S. travel at this time. Do you see it differently?
No, yeah, I did hear this morning in a meeting a suggestion that, if we look at rates and denominators, that there might be some hotspots in the U.S. that may be close to or even exceed some of the bands internationally. So that maybe you want to take that into consideration. I don't know. But, I think we're balancing about the panic. You don't want to incite panic. You don't, the complete shutdown and paralyzation. So I think it has to be prudent. I think it also depends on how old you are. I'm at that crest age where I'll probably be staying at home, but I'm not 18 to 20. So I regret to say.
Yeah, and I would say probably another thing is these decisions are going to be individualized. So you could be a younger person with an underlying chronic condition, which would put you in one of those high risk groups. So, where you're going, just take practical steps and you should be fine.
You can't go to South by Southwest, but that probably wasn't the best thing to do. Or, a large gathering perhaps, but I think.
Well, wherever you go, remember the precautions of washing your hands regularly while you're going there, the touching of the surfaces. Remember to disinfect things that are commonly touched. So take precautions.
I have a question. Thank you for an informative presentation. One of the concerns I have about the mitigation of that curve, of making it flatter, is that in our particular healthcare system, as opposed to the European healthcare system, people with symptoms have to pay for testing, and they also may have huge bills if they end up having to be hospitalized, which could result in a very large amount of people not being tested, not isolating, not quarantined, which would just add to the community spread. And I'm wondering if there's any systemic thought being given to that, because those are the kind of principles that underlie our healthcare system.
That's a very good point. And I didn't make the point when I was talking about testing. Testing at the State Hygienic Laboratory is for free. There's no charge for that testing. So hopefully if someone goes sees their healthcare provider and needs to be tested, there's no obstacle for them to get the tested. We don't charge for any of that. If it goes to a commercial lab, there is a charge.
So it said CDC that for people with underlying conditions such as cancer and compromised respiratory systems, that it leads to a greater risk of mortality. What about people with autoimmune diseases such as rheumatoid arthritis or lupus? Is it the same as cancer and respiratory compromised respiratory systems?
From my perspective, those diseases could impact your immune response. And I would say precautions should be based on that in consultation with your physician.
We do have one question from our online audience joining us by Zoom. And the question to, I don't know who on the panel, you guys can decide. Should we be using the gym?
You know, I read where the Italians were advised not to go to the gym. I would say, and this is anytime you go to a gym, be careful what you touch. Wash your hands afterwards. Don't touch your eyes, your nose, or your mouth if your hands are dirty. But to give up your exercise because of risk of touching something in the gym, I think would be minimal if you take the right precautions. And probably people who are feeling sick aren't going to the gym. At least I don't. So
Next week will be a good time to go to gym. Spring break.
Yeah. And I would say if your gym's really crowded, maybe go in the off times.
Thanks again for the panel. I mean, it's been excellent to understand the system more. What's been a little confusing to me is I think that, well, I mean, I think that partially we do know a lot about non-pharmaceutical interventions, and we know what works, and we know what will get people to change their behavior. And I feel like that part of our knowledge in public health has not been used very much. So we're sending out these messages. Everybody has heard them, right? Wash your hands, stay away from people, etc. But we haven't been sending them out in a way that we know will change people's behaviors. In fact, the way that we've been sending it out, if you take, a health behavior theory that's the most simple, which is the health belief model, right? We start with susceptibility and severity. I would probably say that most people feel like they're potentially susceptible, but the message is this is not severe. And we know that nobody is going to behave unless you have both those things, susceptibility and severity. And in the way that we're sending out the message, we are not using what we know about behavioral science and change in behavior to get people to actually do these. It's not enough to send a message. We need to be also thinking about evidence and science in the way that we send the message. So do you have any thoughts on that, or how we could get better at actually sending out a message that fits with what we know about behavior change and actually might get people to behave in the way that we'd like them to behave and therefore flatten the curve?
not surprisingly, I agree as a behavioral scientist. But, you know, I think that that's oftentimes an issue in this issue of risk communication. I think you've hit it on the head. But I will say I've been extremely pleased to hear that in talking, at least with our university, in recent conversations, that they've been very interested in tapping into our knowledge just in a conversation in the last 24 hours around crafting messages to students, particularly when we go to this next phase of online courses, but still, like, you know, how do you get out risk communication about the gym and the pluses and minuses, or what to do in the dorm, or, you know, even Ryan told me I couldn't do it. He actually didn't say that, my assistant, but I wanted to show how do you wash your hands, because when I finally looked at the video, I was horrified of what 40 years of what I thought I was doing correct was not really correct. So it's not just singing happy birthday and doing what I was doing, apparently. So I think these are things that we can't take, or even if you look at the CDC instructions, it says for hand washing, and I don't mean CDC, I'm not piling on, but, you know, it seems intuitive till you look at it, and it says, you know, turn on the water, wet your hands, turn off the water, then put your hands under the running water. And I thought, how did that happen? So if I know some literal people, they might wonder what happened to that step, but I think these are the kind of messages. So.
Over here. So we know that the Ebola outbreak has just concluded in terms of its time frame and everything along those lines. Given the potential length of what we're expecting with COVID, are there contingency plans for education beyond April 3rd that we're exploring right now?
So I think, you know, you'll see in the message that what we're doing that 2-week period out. I think that that then we'll review that, and if we have to do 2 more. So I think it is very fluid. We'll see where we are at that point. You know, what our infectious disease experts sort of suggest we might need to do, and similar with the international travel. I think that's at a month out. I think there is some language that it will move up another month until we get a real good handle on that.
Won't throw it at you. So you mentioned that the coronavirus has a high likelihood of mutation. Are there concerns that the one that's in the US or around will mutate, and how would that affect screening and testing for it?
Yes, that's a very good point. It does have a high mutation rate. Sometimes viruses mutate so they're not as infectious and not as contagious, or they could up their mutation. They could be more pathogenic. So that's why it's so important for us to watch carefully and determine it. Fortunately, with sequencing that we now have, within a matter of 2 to 3 days, we can sequence strains and compare them to past strains. So if something caused more illness, some strain would be causing more illness or more fatalities, they could quickly compare it to other strains and find out. In fact, we have the capability at the hygienic lab to sequence viruses as well. We haven't done it for this particular one yet. But that's how we would respond to it. That's how we would detect any mutations. And we are concerned about that.
Yep. I was wondering, so this is going on in Italy, of course, you mentioned the Italians. Is that kind of the model that we're looking at here, or have we learned something from them in that situation that allows us to prevent it getting to that extent? Just curious.
I don't know. I don't know if that's the right thing to do or if that's too dramatic of an action to take. My ancestry is Italian, so I'll add that Italians are very dramatic about things. So it could be that, but China took that action too, and it seems to have had good success with it. So in that case, in their practices of hugging and kissing and to greet each other seems to add to the transmission route. So there's probably are a lot more items to consider than we have in the United States.
Hi, sorry, I had a quick question. So you rightfully noted earlier that this isn't the first viral infection, that the world has faced. So what, in your opinion, is setting COVID-19 apart from the rest? I mean, it's a coronavirus like other coronaviruses we face, but for some reason, the media, the world, I mean, we're all freaking out for like, what? Is there something that that is making it, justifying that, or
No,
we're just going crazy
no.
out here?
As Robert was remembering about 2009, I was around for 2009, and people didn't get as freaked out about that. I think it's because it's new. We don't know what's going to happen with it. We don't have that experience. I mean, influenza virus, as many people have pointed out, has been around every year, comes every year. People don't seem to get that enthusiastic about it, getting their vaccine to prevent getting influenza virus. But something new, then all of a sudden, people who never get a vaccine want a vaccine for COVID-19. So I think it's more of a behavioral issue than it is, and I'm not an expert in that area, so I'll stop.
In 2009, 2010, I saw both ends of the spectrum. I saw people that were completely complacent and just disregarded it. Then I saw people on the other end that were getting ready to shelter in place forever. So I think it's just part of the normal reaction to something that's unknown and kind of scary, and they see what's happening in China and Iran and Italy, and maybe they project that and say, oh my God, what's going to happen here? It's that unknown, I guess. So I think it just happens. And from a public health perspective, we need to educate and get people to maybe calm down a little bit. This is definitely not the time to panic. It's not the time also to be completely complacent and go to Seattle for a vacation. So the point is, there is a concerning thing that's happening out there. We need to be serious about it and just take appropriate precautions based on the facts that we have.
And I think it's also where you get your media too. I mean, social media is used a lot for good reasons, and also can get kind of carried away as well and get people thinking, this is the worst of the worst. So just keeping all of that in mind. I know one of our neighbors was like panicking, what should I do? And it's like, take the precautions and don't travel right now internationally and things like that, and just reassure them. Our son from LA texted me the other night and said, there's no toilet paper at the stores. It's like, use Kleenex, be flexible. Don't worry, don't panic. That's the main thing.
So I was wondering, I know the thought process behind the online classes, but what was the thinking towards letting all these students come back into the dorms and keeping the dorms open, keeping the dining halls open?
This is, as I said, just came out today, so I know what in terms of what's in the email. I do know that there has been, I think, and Mike has probably maybe been part of it. I think, are you part of the critical incident management team? I don't know. Because you've been doing the testing. But I do know that there's all of these decisions, they're balancing, like, there's a certain percentage of folks in the dorms who have nowhere else to go. So if you close them down, what are you doing, or in access to food? I think, as with all of these decisions, that they will be evaluated, and we'll see again as we go forward. But I think that that seems to be, one of the reasons that I have heard when they were thinking about it, of why that might be the case. So.
Less of a question and more just of a comment. I feel like as we're seeing videos, people like mad rushing, grocery stores and other things and hoarding on items, I feel like not enough conversation is going around the fact that it's a privilege to be able to buy en masse for weeks on end, since, like I said, a lot of us people do live from week to week. And so I guess, how do you think maybe, I guess I'm getting a question on this. How do you think maybe public health could be more open and transparent about the disparities that we are facing, and telling people, okay, stay inside for 2 weeks and have enough for that when I don't even have enough, until the next day, right? And so I feel like I wish more conversation would happen about that, because there are plenty of people that that's not a reality.
I thank you for that, and I think it echoes the comment in the back about if we are going to control this, then people have to have access to testing and to healthcare, et cetera, and to those. I think some of the areas where I think we have in public health have to keep reminding people, back to the behavior change, that there are some procedures that you might say that you are going to do that ignore that people are on different kind of levels of ability to do that, such as what you're saying of hoarding is actually something that is a sign of privilege, that you can go buy massive amounts of toilet paper in LA. But I think that it's up to us to remind them that, in an epidemic of this proportion, in a community, and I'm using community writ large of the whole United States, that what is going to protect us all are the decisions that we make based on people's ability to do what we say that they need to do. And so everything from, distancing from if we get to points of what are you going to do with employees and working from distance, I think we have to think about the disincentives that we sometimes give people. If they don't, if child care closes here, people can't necessarily afford to stay home, or if they, their employer won't let us. So what are those kind of policies that we have that we need to stress? You really need to think about this, because it might be counterproductive to what we're trying to do, which is make all of us safe. But I think it is up to us in public health to do that. I will say that as part of the public health community and deans, that there has been a sort of discussion of and sort of an op-ed you might have seen about healthcare that came from two kind of different public health areas that had written op-eds for the New York Times. It was in the past New York Times. One where from deans of schools of public health who've been asked to sign on in terms of some of the court decisions before us now, such as the Affordable Care Act. And, if that expands sort of the coverage of folks in this country, then that is crucial during an epidemic, that we have health care that people can access for that. So I think there is a movement of public health people sort of trying to push that. And I'd say all of us need to do it, because this is a prime example where making sure that we take care of equity issues makes all of us safe. All, I want to underline. Okay. All right. Well, thank you all, and wash hands. And thanks to the panel.